I am so delighted to have the opportunity and be fortunate enough to introduce this individual. I had never had the opportunity to meet before, but I followed her on Twitter, and in a time, particularly during COVID, when I needed voices that reassured me that at a federal level, there were things that gave me joy and that I really thought were voices that spoke truth out in the universe. And so I really am grateful to that. And just really excited. I just wasn't sure she'd actually be able to come, and she did. So I would like to introduce Regina LaBelle to you. She is a distinguished scholar and director of the Addiction and Public Policy Initiative at the O'Neill Institute. Working at the intersection of law and policy, Regina's work focuses on identifying policies to reduce overdoses and using the law to promote access to quality addiction treatment, harm reduction, and recovery support services. Ms. LaBelle also founded, directs, and teaches in the Master of Science in Addiction Policy and Practice program at Georgetown University's Graduate School of Arts and Science. And so I'm going to stop talking and introduce her and have her come for her talk on the greatest myths that drive the nation's drug policy and how to develop a roadmap for change.
Thank you so much. Thanks, everyone, and thanks for hanging in there for your last session of the day before you go see some of those great posters and have a little social hour. So I'm really glad to be here, and I'm happy always I live in the DMV area, DC, Maryland, and Virginia area, and I'm always happy to get out and see what else is going on in the world that's not within the Beltway, because I've lived there for quite some time now. So as Jennifer said, I am at Georgetown University, and I've been there on and off for 5 years. And what I'm going to talk about today, these drug policy myths and a roadmap for change. I direct and teach in this 1-year master's program. And the master's program was really born out of I worked for the mayor of Seattle for 8 years. I worked in the Obama administration for 8 years. And it was born of my desire to do something other than learn on the job in drug policy. Or too often, we just approach addiction from the I knew a guy approach to addiction policy. So my old boss, Michael Botticelli, who was the drug policy director in the last half of the Obama administration, was a person in long-term recovery, and he would always say that was one of the biggest myths driving drug policy was the I knew a guy. So I knew a guy who, entered recovery based on this, so that's what I'm going to recommend to everybody else. Or I knew a guy who just, this was their recovery path. So our goal in this master's program, we're in our 3rd year, our 3rd cohort. Our goal is really to match the science and the evidence, but really most importantly, make sure that our students understand how to move those policy levers. So in the next 40 minutes or so, I'm going to condense my year-long program without the neuroscience, because I'm a lawyer, not a doctor, and kind of help frame these issues, science, evidence, and policymaking. How do we go from this should be the case to this is how it gets done? So I have no financial disclosures, and our learning objectives, as I mentioned, we're going to talk about the myths, we're going to talk about where science and evidence diverge from policies, how current drug policies are, and then lastly, what the policy levers are. So US drug policy, science, and evidence. And what I'm going to focus on here is the public health continuum of care. And we think about this now, and looking at drug policy, addiction policy, from a public health continuum of care seems like something we've always done, and it really hasn't been looked at in this way for that long. So I'm going to start with prevention. And this is just an overview of what the science says, right? So prevention, what do we know about it? Prevention science shows that adverse childhood experiences drive youth, risky substance use, and the later development of substance use disorder. And when we talk about these adverse childhood experiences, what are we talking about? We're talking about incarceration. We're talking about family separation. We're talking about homelessness, all those social determinants of addiction. That's what the science shows. We also know from science that reducing these adverse childhood experiences can reduce poor outcomes, poor health outcomes overall, but specifically for substance use disorder. So again, what works? Economic stability, home visitation, early childhood supports, emotional supports, mentoring, and after-school activities. Those things go into the social determinants of addiction, reducing those adverse childhood experiences and improving prevention. That's what prevention science shows. Treatment science. This is where the I knew a guy approach mostly comes in. Okay, so first, medication treatment, this is indisputable, science shows. Medication treatment is the standard of care for opioid use disorder. National Academies of Science, Engineering, and Medicine said this. The World Health Organization has said this. That's a fact. Stimulant use disorder is best treated with contingency management. And we also know that reduced use may be a meaningful outcome. Lastly, in treatment science, we also know that recovery from a substance use disorder, it might require long-term treatment and multiple attempts. All of these are what the science shows for treatment. Sorry. How do I go back? Okay, harm reduction. Harm reduction, what do we know? Again, science shown since the 80s. Syringe services programs reduce blood-borne disease, Hep C, HIV. It's a fact. Harm reduction services don't increase drug use. And lastly, overdose education and naloxone distribution programs reduce overdoses in communities where implemented. This is from a study from Massachusetts. So saturating a community with naloxone will decrease overdoses, morbidity, and mortality. These are just some of the things that we know about harm reduction. Lastly, recovery. So recovery is defined by SAMHSA, HHS's SAMHSA, as a process of change through which individuals improve their health, wellness, and leading a self-directed life and strive to live to their full potential. That's the definition that SAMHSA has. They call it a working definition of recovery. We also know that it includes health, home, purpose, and community. All of these elements form recovery. And it's important that we include recovery in that continuum of care. So that's just some of what the science says and an underlying basis of the continuum of care. So now I want to go pivot to those myths, right, that underlie many of our policies that we have at the state, local, and federal level. So first, prevention in practice. So prevention in practice, shaming parents. We shame the parent, and it's usually the mother. We shame the parent, they're going to stop their drug use. If we separate the child from the parent, we're going to shock her or him or they into not using drugs anymore. And it'll help their substance use disorder. So we've tended to look at those individual factors that might lead to individual risky substance use rather than those social determinants of addiction. And I think that shaming parents has led to a lot of our policies, particularly in the child welfare system. And also it keeps, we know this from research, that it prevents pregnant people from seeking out care. It prevents them from getting prenatal care, and it also leads to family separation. Treatment science. I think the myth that medications are swapping one drug for another has pervaded our policies for many, many years. And when I entered the Obama administration in 2009, I heard this quite a bit when I was going and talking to people in the field. That, buprenorphine, methadone, you're just swapping one drug for another. That's not real treatment. We hear that less now, but it definitely is something that moved our policies for quite some time. The other myth that manifests itself in our federal policies is about contingency management. So the federal government puts a limit on the amount of money that can be used for contingency management. It's not based on science. There are other restrictions about contingency management, but those myths that we're basically paying drug users, and they're just going to use anyway, has underlined our approach to the only proven evidence-based approach that we have to treating stimulant use disorder. And then lastly, despite the fact that we have the Parity Act at the federal level, it's enforced by the federal government as well as state insurance commissioners that parity enforcement requires mental health to be covered at the same level as physical health. And still, we have insurance companies that deny treatment, that have pre-authorization requirements, and put up barrier after barrier that are not based on science or evidence, but too often based on myths, stigma, and misconceptions about treating substance use disorder. Harm reduction. I think this is probably the one where if you look up harm reduction, it probably would have in parentheses myths after it in a dictionary. This is probably where the majority of the myths drive our approaches to harm reduction. And they undermine our ability to engage with people. So the bans or limits on syringe services programs. We were talking at lunch today. The state of Pennsylvania has a statewide ban on syringe services programs. That doesn't mean they don't exist in the state. They exist in the state because Philadelphia and Pittsburgh used executive authority, actually in contravention of state law, to have syringe services programs in those cities. The myths of harm reduction marginalize harm reduction programs throughout the country and make them look like it's just an add-on, not part of the continuum. And lastly, limiting naloxone availability and distribution. So as I mentioned, I teach in DC, I live in Maryland. The District of Columbia has one of the top 5 overdose death rates in the country. Not something anybody ever talks about. We always think of West Virginia, we think of other states, don't think of DC. DC has had it for quite some time. Now, DC has a law on the books that you can't train a trainer in naloxone distribution. You have to be trained by the Department of Behavioral Health in DC in order to train someone on naloxone. That's what the law says. And they've gotten around this law. They've got, you can call up, you can get it distributed. But what happens is it limits, it's an unscience-based limitation on expanding access to naloxone in DC that desperately needs more naloxone distributed to communities at risk. And then lastly, recovery. So I think the biggest myth about recovery is that it's a nice to have, but it's not necessary. So it's kind of the social part, right, of the continuum. We don't really need this. When we know from the science and evidence that recovery supports, which include housing, community, health, they not only extend lives, they help a community, they help the individual, they help people live to their full potential. But stigma and collateral consequences, so collateral consequences are basically if there's a drug conviction on someone's record, that can prevent that person from sustaining their recovery. Why? Because it might prevent the individual from getting access to housing. It might prevent the type of job they can get. And so all those collateral consequences stand in the way, and they're based on myths. They stand in the way of someone's sustained recovery. And then lastly, discrimination and the violation of federal laws. I'm going to talk about the Americans with Disabilities Act in a little bit. The Americans with Disabilities Act is an incredible tool that is too often underused for people with substance use disorder, because the Americans with Disabilities Act covers people with substance use disorder. Now, it needs to be looked at because it unscientifically distinguishes between alcohol and other drug use disorders. It does make that distinction. That should be amended. However, people are protected. If you have a substance use disorder, you're protected, you're covered by the Americans with Disabilities Act, as well as other civil rights laws. So that's another piece, and it hadn't really been enforced in that way for a long time, basically because of stigma, discrimination, and that's not really what it's meant for. It's not meant to cover those people. So across the continuum of care, those are all the myths that drive the nation's approach. So now I want to talk about, excuse me, those policy levers. So what policy levers, oh, this is a quiz for you, because I was asked to do a quiz, so I came up with this quiz. It's not as serious. Your first speaker took it really seriously. You did a great job. Sorry, what are the policy levers that will drive change? And maybe you think one of them is. It's A, because some of you are really good at that. What are the policy levers? I think there's a tool that someone's supposed to be doing. You got it. Great. Thank you. A.
You're being silenced.
All right. Almost everyone is giving you the answer you want, though there is a surprising level of executive action in there. I think we've got some people who want the filibuster removed, but federal state legislation.
Great. So the policy levers, so the most common answer was B? Okay, cool. So it's B, C, and D. All of these things are levers to drive policy change. And this is something when I was teaching class last week, you know, my students because the Congress is the biggest example, right, we think it's the biggest example, although they've only passed 38 pieces of legislation this 118th Congress, which is the least effective Congress ever, if you gauge it in terms of the legislation they pass. So what's happening, that is very important, legislation is very important, but it is not the sole policy lever. Executive actions are a policy lever, and litigation can be a policy lever. And I'm going to talk about B, C, and D. So I'm really glad that was the answer, because that's something I think we think about, that you've got to do the I'm just a bill thing, that it has to be legislation. And it doesn't have to be legislation to really affect change. Thank you for those of you who are familiar with Schoolhouse Rock. Okay, so legislation. I'm going to start with that. It's the one that we're most familiar with, right? Hardest one, hardest. But we'll talk about that. So state legislation to decriminalize testing strips has really taken off in the last couple of years. And I was really pleased that your governor last year supported taking testing strips out of the drug paraphernalia law in the state. And these are things that when I started in the Biden administration on the afternoon, we were sworn in on the afternoon of the inauguration. And I went to the office the next day, which if anyone wants to know what that was like, I'm happy to talk to you about. So testing strips, fentanyl testing strips, when I was at Georgetown between administrations, I kept hearing that you can't use federal money for drug testing strips. You can't use it. And I kept drilling down saying, why? Tell me why, because I was talking to state officials. Tell me why you can't. And finally, someone said, well, there's this blog that was put up by the SAMHSA director that said you can't use, it's not an evidence-based practice, you can't use fentanyl testing strips. You can't use federal money for fentanyl testing strips. So when I went, first week, I called my friends, the new folks at SAMHSA, and I said, can we do something about this? And that was one of the first steps that we took, was to just take the blog down. It didn't require legislative action. It required the awareness, drilling down, and persistence. It was my bugaboo for a while to figure out why states couldn't use this. But once that went out, it was a very bipartisan effort on Capitol Hill. And we talked to a lot of members on both sides of the aisle in Washington, D.C. about why this was important. And so there was a ripple effect across the country, that states across the country then were taking steps because there were community groups that wanted to distribute fentanyl test strips. And so the states, it spread across the country to take fentanyl test strips out from under the drug paraphernalia laws. Now a lot of states made it broader to be just test strips, drug testing strips for any drug. But that was an important legislative action, but it had to be done at the state level. Federal level, pretty easy, take a blog down. Secondly, state legislation to remove barriers to naloxone access. It's another little story from the Obama era. When I came in, the policy was that we didn't want to distribute naloxone other than first responders had it for a long time, EMTs had it for a long time, other medical professionals had it. But we debated about whether or not we should allow it to be broader and more expansively allowed. There had been the thinking previously, and this is where the myth drove the policy, that we just need, it might be good for somebody to overdose. So naloxone should not be widely distributed, because maybe that's what they need. And I'm not kidding. This was said by an official about why we shouldn't distribute naloxone. That's a myth that drove policy. So we started with law enforcement. We didn't end with law enforcement. We started with law enforcement because we wanted to bring them along so they understood why. And that state of play, it was mostly rural areas, and they were the first responders. So we were able to expand access and remove those barriers. Most of the barriers relied upon state action. So we started with getting cities to have their medical officers provide for greater access, so you didn't have to have a prescription. And now we're at the stage where we have at least one form of over-the-counter, and then another one should be starting to get there available soon. Another piece of legislation, so those are the good stories. I'm going to talk about the harder stories. Right now, in Congress is being debated legislation that would expand access to methadone, and that's the Modernizing Opioid Treatment Access Act. What this legislation would do is it would allow addiction medicine specialists to prescribe methadone, and it could be picked up at a pharmacy. So that would change from just having OTPs provide the methadone, and it would allow addiction medicine specialists to do that. So that's in the House and the Senate right now. And I want to tell you something about how important it is to build these bridges. So the Republican co-sponsor of that legislation is a congressman named Don Bacon from Nebraska. Now, Don Bacon from Nebraska is a very conservative person. He also is someone who lost 3 family members to overdose. So the people working on this legislation have talked to him, and he's taking a lot of heat on this issue because there's a lot of opposition to expanding access to methadone. But he, along with Democratic colleagues that he has very little in common with, other than this issue, are working it. I'm not sure it's going to pass in the 118th Congress, but just like the next piece of legislation I'm going to talk about, it might take 2 or 3 tries. So the MAT Act of 2023 passed, basically modernizing addiction treatment. What it did was it removed the requirement for an 8-hour training for a physician to prescribe buprenorphine, or a 24-hour training for nurse practitioners, physician's assistants to prescribe buprenorphine. We got rid of that. Now, anyone with a controlled substances license can prescribe buprenorphine. That hasn't changed the world. We haven't seen a huge uptake in the number of people prescribing buprenorphine because myths have driven that. Myths drive who's taking care of people. And one of the myths, when there's a survey about this, that doctors choose not to, there are two primary reasons why they're not choosing to prescribe buprenorphine. One is because they don't have the clinical experience or feel that they have the clinical support to treat people appropriately. That's an issue that with more education, with more support, clinical support, we can overcome that. That's going to take a little while. The second reason is driven by myths, and that is that when surveyed, doctors say they don't want those people in their waiting rooms. Now, here's the thing. Those people are already there. They're just not treating them. They might have an alcohol use disorder. Probably more likely they have an alcohol use disorder. They probably have an opioid use disorder too, but they're present already. So we have to get rid of those myths. It's another myth that's driven these policies. The last 2 pieces of legislation are also the Reentry Act. So individuals who are currently, if you're incarcerated, you cannot receive Medicaid coverage, the federal match. So the Reentry Act and the Due Process Act, and we also know that individuals upon reentry are up to 10 times greater risk of overdose death in the first couple weeks after they leave incarceration. And why is that? Because withdrawal is not treatment, and they're in jail, they're not receiving treatment for a chronic use disorder, and when they leave, they're not treated, so they may use at the same level, and they're overdosing and dying. So this legislation would allow for 30 days prior to reentry for Medicaid coverage to kick in. We also know this is a population that has greater heart disease, greater rates of cancer, and so providing them with Medicaid coverage prior to reentry would give them a better chance. It reduces recidivism and also extends their potential for recovery. The Due Process Act provides for, so if once you're booked, once you're in jail, your Medicaid cuts off. It might be suspended, but it ends. The Due Process Act allows for people in the first 7 days to continue their Medicaid because you may not have been adjudicated yet, right? You may not have been guilty yet and sentenced. So the first 7 days, they would allow for Medicaid to cover. Those 2 pieces of legislation are very costly because they're not basing it on how many lives are saved, et cetera. So that's a piece, those 2 pieces of legislation I'm not sure are going to make it out. But they, again, are driven by maybe, again, we got to shock the conscience. People need to be punished. If they go in, they shouldn't receive treatment, even though they have actually a constitutional right to adequate health care in correctional settings. So I want to get into the executive actions. How am I doing on time? Okay. So executive actions. And this is where often we have to turn to executive actions because getting things legislatively done is so much harder. So I talked about one, which was the test strip piece. I want to talk about another one. So this was 2016. We have moved a great deal since that time. But in 2016, as I mentioned, Michael Botticelli was in recovery, long-term recovery from a substance use disorder. And he was very committed to changing the language that we use in the federal government. So in January of 2017, the last thing we sent out at the Office of National Drug Control Policy was a memo to all federal agencies about how to talk about substance use disorder. Now, legislation is required to change the name of some of these agencies, but again, also the Associated Press has changed its standards for language. We communicated with them about that, said it doesn't reflect science. When you use these terms, it reflects myths and stigma. And so we were able to get that done. It was just not easy because there are many levels of review in the federal government, which is okay. But we were able to get that done without asking for someone else's approval. Rulemaking is another really important policy lever that I think it's hard. It's a difficult thing. There are administrative lawyers who work on this, make their living at. But the whole purpose of the federal rulemaking process is that individuals who are affected by it can have a say in the outcome. So there are two pieces of federal rules. This is another policy lever that's really important. So during COVID, as many of you know, the federal rules around telehealth and methadone were relaxed. Take-home methadone were relaxed. So they gave an opportunity, researchers researched it. What did they see? First of all, they saw that take-home methadone did not result in more deaths from methadone misuse. It also showed, qualitative studies showed, people were happier with their treatment. And they also maintained in treatment for longer with telehealth and methadone, those changes that were made. So rules were proposed a couple years ago, and the telehealth rule, what would have happened then is they had changed, the Drug Enforcement Administration proposed to change it to require 30 days that you had to see someone, an in-person visit within 30 days of getting a telehealth visit and a prescription. There were 38,000 people who commented on that rule. The Drug Enforcement Administration had an all-day listening session. I think they felt the blowback. And now that rule, the one that allowed for the flexibility that was present during COVID, has been extended till the end of the year. So they'll issue that rule again, and we'll see what they do. If they make another 30-day requirement, they'll probably get 50,000 comments this time. But rulemaking is a really important piece of the policy levers that people can influence. And then the same with methadone. So those take-home rules on methadone, it was the first time that flexibility was allowed. That was federal flexibility. Now states can decide whether or not they would abide by the flexibility. The majority of states did. So it allowed for expanded access to take-home. Because the way the methadone system has been established has not been based on science and evidence. It's really been based, in my opinion, on a punishment program. That you're punishing someone for being bad enough that they needed methadone. And that's what our system has looked like. So when we went into the administration, we did a couple things. One is we asked NASM to do a review of the methadone rules. And then SAMHSA put out a rule that received comments back, not as many as the telehealth rule, but they just issued those final rules a couple weeks ago. Those methadone rules now allow for expanded take-home. So if you are in the early stages of methadone treatment, you no longer have to go every single day in person to methadone, which interferes with employment Daycare, just living your life, and we talked first about recovery, interfered with all those things. So that rule that just came out, you know, there are other changes that should be made, but it allows for expanded access to take home. It also allows now the requirement that you have to have a diagnosed opioid use disorder for 1 year before you were eligible to be in an opioid treatment program. That is not based on science or evidence. That is just based on, I'm not sure what it was based on, that I really don't know. But that was done away with in this final rule that was issued. So again, another way to make change is through the rulemaking process. And then lastly, just general policies. So grants, what does the block grant say? What are the block grant priorities? What is the opioid response grant priorities? All the other grants, all those things reflect priorities and that can be influenced by the executive branch without having to go through the legislative process. And then lastly, litigation and enforcement. So because I'm a lawyer, I have to talk about this, but it's important. So litigation in and of itself is not a strategy, but litigation can sure focus people's attention on an issue. The Department of Justice in 2022 issued guidance on the Americans with Disabilities Act and the use of medications for opioid use disorder. And they said very clearly, for the first time, the denial of medications for opioid use disorder, requiring people to get off of medications as a condition of getting into recovery housing, going into a jail, going into a long-term care facility, violates the Americans with Disabilities Act. Full stop. I felt like that too. It was very exciting when that came out. So that guidance, that didn't require legislation. I mean, the ADA required legislation. That was hard won back in the 90s. But all this did, so then what happened following up is all the assistant US attorneys across the country, Massachusetts has been a leader in this, New York, in Massachusetts, they did a full review of all of their court system, jails, and they said, you know, you're in violation of the Americans with Disabilities Act. And there were key lawsuits. So this still isn't done. Right now, we have 30% of jails in the United States provide buprenorphine, and 20% of jails provide methadone. And even smaller, it's mostly continued buprenorphine or continued methadone if you're already on it. But this is an area that's ripe for litigation. It's also because these activities are happening, these enforcement activities are happening, it's also in concert moving this legislation on the Hill and in states. So many states across the country last year, in the last couple of years, have passed legislation to require jails and prisons to include medications and to initiate medications. So the state of Rhode Island was the first one to do this. They decreased overdose deaths upon reentry by 60% after a year, and by 6% overall. 60%. There's very few other interventions that would lead to that type of reduction. Of course, it's important, and I have to say this, you shouldn't have to go to jail or prison in order to get treatment. And my concern about this is you need to build up the community-based treatment as well, because upon reentry, where are you sending people? So all of that also has to happen. The Equal Employment Opportunity Commission also put out a piece about licensing. So there was a woman in Indiana who was denied access to, she's a nurse, denied access to a state program for treatment of nurses with substance use disorder because she was receiving buprenorphine for her substance use disorder. So the EEOC said, no, you can't do that. That is a violation of the ADA. And so the woman was able to get her treatment. Indiana changed its rules, And that, again, that's reverberated across the country. We're still not 100%, but we're better than we were 10 years ago. And again, enforcement actions have to be combined. And one other example, in New Mexico, there were people who were talking to the New Mexico jail system about litigation and what they were going to have to do, and because they were violating the ADA. And that led to legislation being passed. So the goal is not simply to litigate, it's really to move policy. So you don't have to live in a state or be in a jail where someone just happens to litigate. You've got to change that policy and change attitudes and bust those myths. So I have a ton of references for you, and I want to leave you with just, I know that government can be frustrating, policy making can be frustrating. It is to me, but I really think that the solutions are in this room. You all come from so many different backgrounds, expertise, and everyone has a role to play. And tomorrow I'll teach my class again, and I feel like the future is in really good hands, both with the people in this community who are going to move these policies forward, as well as with the next generation of policymakers who are going to address issues we didn't even know exist today. So with that, thank you, and I'm happy to answer any questions.
Thank you so much. Before Lucas runs to the mic, please take advantage of the microphones to ask questions. I'll ask some of the Hoover questions as well. I do want to just ask one question related to methadone. I'm going to sit down so you can see me maybe. Do you have exemplars that we might be able to use as examples for TxSUS related to pathways to encourage the state to operate or align more closely with the capacities we have at the federal level? I'm just curious because I think that's something that would benefit us to hear your thoughts if you have any. Thank you.
Yeah, I mean, I think, so, the data, and I'm saying this to a researcher, the data are important. You should always lead with the data, but it's more like, are there people, is there, what's a compelling case that can be made? Are there narratives of individuals who are able to sustain their treatment, stay in their job, and take care of their children better because they weren't required to do the daily dosing, in-person dosing? So finding those narratives, and there's some good organizations out there that provide that information. So I think storytelling can be helpful as well, and having people with lived experience talk about it.
Hi, Lucas Hill, UT Austin. Our team at the Farm Program and some others in the country have researched the problem of pharmacies being reluctant or not willing to engage in buprenorphine dispensing, and that being, in some cases, and in a growing number of cases, related to past civil litigation and red flags that have been outlined by the DEA. More broadly, there certainly has been other discussion at the conference of fear about the DEA, even potentially expanding beyond fear that the DEA intends to invoke. Do you feel that the DEA's outsized impact on practice relates to their scheduling authority? And do you think that changing the way that controlled substances are regulated in terms of scheduling would have any impact on that? And if not, what do you think could be done to rein in some of that broad-ranging impact of fear about the DEA from impacting practice across the board?
Yeah, that's a complex question. It's a good question. There's some, so Talid El-Sabawi is a scholar with us, and she wrote a piece about why the DEA, not the FDA. So there's some research out there, some interesting discussion about how you could move towards that piece of it. Because, the controlled substance piece of DEA's work is fairly narrow, fairly small compared to all the other work that DEA does worldwide. So an argument could be made that you could carve that out. Now, that would be difficult to do without a compelling reason. And I'm not saying there aren't compelling reasons, but there are people who would not think that there are compelling reasons. Law enforcement discretion is another really big challenge in this area. So you could go to one area of the country where you have special agents who may not feel the same way. Some of it is based on personal relationships. That's where I think, you know, having that open communication, talking to the special agents in charge in your area is also a good idea. The bigger, broader issue of buprenorphine availability, I'm concerned if the methadone legislation passed, I mean, we have a hard time with buprenorphine, what about methadone? Those are, again, every time we do something, it has like 3 more bills and other pieces we need to look at. So, you know, start with the personal relationship.
I'm Sophie Prima. I'm with Texas Rio Grande Legal Aid. I'm also an attorney, and my understanding of the Americans with Disabilities Act is that the protections for people with substance use disorders is limited to people who are not engaging in, I think they say, like, illicit use of drugs. So
right.
Basically, if you are using drugs, then you are not covered, you're not protected. And then also, I mean, there's language about, like, person who's diagnosed with a, you know, a substance use disorder, like, what is a substance use disorder, and, like, the barriers to even just that, you know, label, you know, and we're in Texas here, and the Fifth Circuit is not kind to people who don't look like the Fifth Circuit judges, you know, and so you have this federal legislation that is supposed to be implemented, you know, uniformly, but, you know, what we see here is that's not the case. I guess my question is kind of, you know, I find it hard to believe that the, you know, federally will move anytime soon towards protecting people who do use drugs on a, you know, under the ADA, but, you know, what is the role of community organizing and, you know, just at the local level to kind of either, you know, hold our government accountable and, you know, legislate and, you know, enforce laws uniformly, or just, you know, to create change on the local level.
Right, thanks. So, yeah, I mean, it was passed in the 90s. It's not perfect. It still carries some of the myths in it. So, you know, you need to have legislative change at the federal level. We have recommended or spoken, educated members of Congress about the potential of having a commission to look at all these issues. We also really believe that don't rely on litigation alone is important. You know, Texas has a strong history of criminal justice reform. That's if you decrease recidivism rates, and it is a, you know, there is an Eighth Amendment right. I'm just talking about this narrow piece of it. That's another way to expand access in the carceral systems. But what you're talking about is a much bigger issue that would require legislative reform. So it's, you know, that has to start, though. No one's really, I don't think there's been much of a movement to go to Congress and say, you know, these need to be updated at least.
Thank you.
Thanks for your work.
A question from Huba you mentioned it briefly. I think it has come up a couple of times, but we haven't really called out this war on drugs. So it's a big question. How can we dismantle the war on drugs? I told you it was an easy one.
Let me get back to. I'll do it in the next 10 minutes. I'll figure out.
Just whip that out.
I mean, I think that So I think it's important to break it down. Like, what are we trying to do? Because I do think that just as, you know, we have, like, harm reduction is an approach. It's also an array of services. You know, what are we trying to accomplish? If you say to someone that there might be some people for whom, you know, getting rid of the X waiver, for example, is one more way of getting rid of the war on drugs. All those little steps you take to follow science and evidence are another way to dismantle a system that has not worked. So I don't know if, you know, I don't know if that really answers that huge dilemma, but, you know, we have to like take it a step at a time.
And in regards to the new rules coming in April for methadone and the relaxation of some of the policies, we have to wait for the state of Texas to make those changes. Would that come legislatively, executively? And if Texas doesn't adopt those new rules, what do we do to fight that and get those rules changed on a state level?
Yeah, so for your state, it would be up to your state opioid treatment authority. And that person, it varies state by state where they sit. So if you have your state SSA, they work, the state single substance authority, they work usually really closely with them. So starting with that person, and some of that could be done through rules and not legislatively, but it also, you know, I think starting with that SOTA, they're called, the opioid treatment authority, that's the first place to engage.
Thank you.
A couple other questions from Huva. This is technical, so I'm just going to read this. Do private nonprofit, i.e. not relying on federal dollars, substance use treatment program related service providers have to abide by the ADA?
So that's a legal question that I cannot give bigger picture legal advice on, and the legal answer is it depends. Sorry, I can't give a good answer.
I think the point that, just so that to give voice to this person, the point that they were making, oh, it just went away on my, Lucas answered it for me. But I think what they were talking about was denial of care or that. So another one, how can substance use or public health researchers who don't really spend a lot of time in the policy space and yet see the importance of it best contribute to positive change in policy at a local or state level? Yeah, great question. First thing to do, use your research. You know, we have to do this research, peer-reviewed journals, that's how you get tenure, all that stuff. What we do is our work is intended to educate policymakers. So we do three things. The first is, not everybody has to do this, but it's a way to do it. It's an example. We might have a journal article, we'll follow that up with a webinar. We always have, our journal articles are always reviewed by people with lived experience. Our webinars always have a person with lived experience on the panel or involved in the development. And then lastly, either do an op-ed or some other, we call it quick takes and big ideas. So researchers are brilliant, but sometimes policymakers have a lot of other things on their plate to look at. So make it as accessible as possible to the broadest audience, or at least to those people you're trying to influence. So making it accessible and having it in different avenues is another way to do it. Dr. Hill, that would be another good TxSUS session. Just a little planning on the fly there. Unless there are final, oh, we already, you get the honor of having the very last question of the day, sir. No pressure.
Great, thank you. Hi, thank you for being here with us today. As a person in long-term recovery and one of those lucky enough to be alive today, I'm mortified, although not surprised, to hear that thousands of deaths across the United States, some of our family members and friends might have been prevented by just educating somebody who had a staunch view on what some of our brothers and sisters were doing. So I guess I want to know, and you sort of answered the question, but what we're doing to increase, not just educate policymakers, I guess, but increase or demand cultural competency as well as destigmatization at the highest levels.
Yeah, thanks for asking that. So one thing that we've been trying to do, we made a concerted effort to do this and I'm pointing this out because it's my experience, Obama and the Biden administrations, was to make sure that we hired people in high positions who could speak to their lived experience. That was really important. And it makes such a difference in our dialogues. It makes such a difference in our outreach. So that's one thing, because as I think Harvey Milk said this, you can't hate up close. Michael Botticelli is a hero of mine. He was our second drug czar in the Obama administration, person lived experience, incredible person. And I would tell you, I would staff him, and our first director was wonderful too, but just different experience. He could go into rooms that I couldn't go in. He could go into rooms that no one else could go in. So bringing people, highly qualified people who can speak to their lived experience. And what we're doing now at Georgetown is my deputy is a person with lived experience, long-term recovery. She has an addiction policy scholars program, 5 people from across the country that we're helping to mentor and build capacity so that they can go on to tell their story and influence policy at the highest levels. So that's what we're doing in our little part of the world, and I would encourage all of you to do the same.